Welcome to FRACP Chats with Dr. Ronald Way. Today I have a special guest, Dr. Leon Chen, consultant neurologist. He's here to talk about Parkinson's disease, a very common short case examination. Welcome, Dr. Chen.
Hi, welcome and good evening.
So today we'll talk about the features of Parkinson's disease. I want to start off by asking you, Dr. Chen, you've examined candidates before and you've had Parkinson's disease patients. What are you looking for? What are the main signs that a Parkinson's patient has classically?
So when we talk about Parkinsonism, there are 3 or 4 main features or core features that need to be present. So firstly, we're talking about rigidity, so that's increased tone in the limbs, typically the upper limbs. And second feature is that of bradykinesia, a slowing down of movement, where you get decrement of said movement along with the slowing down of that movement. And the third is that of a tremor, which tends to be unilateral in Parkinson's disease, and it tends to begin with a resting tremor. Postural instability is the other feature that can be present as well.
That's right, and this tremor is typically described as pill rolling in nature. What about the gait, Dr. Chen? What do you commonly see in the gait that the candidates really need to pick up on?
So there are gait changes in Parkinsonism and Parkinson's disease itself. What you will have to note is that one of the earliest features tends to be the lack or the decrement in arm swing in these patients, full stop. Now, beyond that, the patient might then experience a stooping over in their gait. Gait speed does change in the way that there is decreased stride length both in the vertical and horizontal axis. Initiation of gait can be difficult from a sitting to a standing position and from a standing to a walking task. Movements such as turning can be difficult as disease progresses with turning and block. In addition, you might find that patients may tend to suddenly halt, or what we call freeze, in the middle of a particular task such as walking.
And also, you can sometimes enhance some of the features, particularly of the cogwheel rigidity, by a process of testing distraction or co-activation. How would you, as a consultant neurologist, go about testing this?
So that's one movement, or one maneuver, I should say, that can bring out or make more evident rigidity or the increased tone. So with these maneuvers, you want something that provides the patient a mental task. For instance, arithmetics, subtraction tasks, or performing particular things with the contralateral upper limb, such as drawing patterns, imaginary patterns.
I think one of the things I also like to do during a Parkinson's exam is to rule out other causes of Parkinson's plus syndromes. So for example, PSP or multisystem atrophy. Classically, you would look for an upward gaze palsy with PSP, and in multisystem atrophy, you might have cerebellar signs, and you might also have a very, very significant postural drop of blood pressure. Is there anything else you would like to add to that, Dr. Chen?
Sure, yeah. I do agree with the point that it is extremely important to, once you're done with the examination and you found your signs and symptoms of Parkinsonism, to look for these other features. In progressive supranuclear palsy, what you'd expect to find, in addition to what you've mentioned already, is very early axial rigidity of the trunk and the neck. They can get frontalis overactivation, which gives you that classical appearance of a startled look or startled appearance. I agree in multiple systems atrophy that cerebellar signs need to be looked for. and orthostasis or orthostatic intolerance is a much earlier feature in MSA, although this can occur as well in Parkinson's disease.
And also, I suppose you have corticobasal degeneration, and one thing I note about that is that you have alien limb phenomenon, but I think that might be a bit over the top of the clinical exam. What do you think?
Yes, personally, I guess I haven't seen anyone with alien limb syndrome come in during the course of our examinations. What is important to note as well is that if you do notice any particular upper motor neuron features, such as an upgoing plantar or hyperreflexia, then a case can be made for concurrent corticobasal syndrome. I use the word syndrome rather than degeneration because that's a pathological or a diagnosis.
That's why you're the neurologist. One thing I haven't mentioned is the Parkinsonian facies, often described in older textbooks as mask-like facies. Can you describe what a typical Parkinsonian face is like, and is it appropriate to use the term mask-like facies?
Sure, so that term can be used, but what I prefer to use is a term called hypomimia. That just means a lack of facial expression. What you do catch up on is, for instance, as the term mentions, a lack of facial expression, which can be highlighted by things such as decreased blink rate of the eyes. Or in addition to that, you might want to look for hypophonia, which is a decreased timbre or volume of their voice.
During my Parkinson's examination that I got for the real exam, I had time to ask the patient to write something to look for changes, small writing. What do you think about that in the exam?
Yes, I agree. If the opportunity is given to you, it should be expected that testing for micrographia should be completed. If there isn't the opportunity to do so, volunteering it to the examiners that you would like to test for this is also acceptable.
One thing that I note a lot of neurologists and geriatricians like to do is the glabella tap. Is there any merit to doing this in the examination? What's your thoughts about the glabella tap?
Yes, I think there's some value for you to add it into your examination. It forms a part of the a clinical sign when it comes to disinhibition of frontal release, which can happen in Parkinson's disease in addition to other neurodegenerative disorders. So yes, I agree. It's of some use in the examination.
Can you explain to our viewers how you would go about doing it? Would you just tap their head gently?
So this is the part. An examination that sometimes trips up young players. So what you want to do is, as you said, explain to the patient what you're doing, approach the patient from behind, and tap gently, just in the forehead region, as it suggests, in the glabella region. And what you're looking for is not the blink itself as you tap, but the persistence of blink even after the stimuli has been persistent for a period of time. Now we're talking about maybe perhaps 7 to 8 taps.
That's really good. Another complication of Parkinson's disease is cognitive impairment and Parkinson's disease dementia. One of the differentials is, of course, Lewy body dementia, and you would mention at the end of the Parkinsonian examination that you would like to perform a screening test such as a mini mental state examination to rule out cognitive impairment. Would you agree with this, Dr. Chen?
Yeah, I think that's reasonable for you to volunteer that you'd like to complete a cognitive examination.
And so that wraps things up about the Parkinson's examination. I might just finish off with just one last question to Dr. Chen about any tips in particular with the Parkinson's disease examination, apart from what we've mentioned, that might help the candidates get extra points.
No, I think technique is important and having a system to it, though. Again, the most essential things that I do find that trips candidates up is examination of the tone itself. If you miss the rigidity, it's hard to come back from. Co-activation maneuvers are essential, and observation, during your inspection, is probably the thing that's going to give you the biggest clue.
All right. The one last thing I can think of would be that of advanced therapies. I don't know if you would have someone on an apomorphine pump in the exam. I guess that's possible, or evidence that they may have a deep brain stimulator. What can you tell us about these devices? Would you expect in the examination?
Yes, so you're right about the advanced therapies in Parkinson's disease. It's always worthwhile to look for these extra devices that the patient does have during the examination. It might give you a clue about the diagnosis that they do carry. So, not impossible, and you should look out for it.
And of course, the third device would be that of a PEG tube for duodopa administration. All right, that wraps things up. I want to thank my guest, Dr. Leon Chen, for your expert advice. And we wish all BPTs best of luck with their examination, and particularly if they get a Parkinson's disease examination.